The decision-making and clinical management of liver cancer depends on several features, whether the tumor is primary or metastatic. This talk will focus on hepatocellular carcinoma. Synonyms are primary liver cancer, HCC, or hepatoma in the literature. But just so that you know, the overall most common cancer we see in the liver is not primary liver cancer, but it's stage 4 metastatic colorectal cancer, because there's 160,000 cases of colorectal cancer each year, and just over half, about 60%, will metastasize to the liver. But we're going to focus, because this conference, on HCC. When you're dealing with HCC, as we've already heard, it depends upon the size, location, number of tumors, whether there's vascular invasion, whether it's spread outside the liver, and about 85% of the time, the HCC occurs because the background liver is cirrhotic, and we have Child's classification where A is the least damaged liver and C is the worst. The take-home message for this lecture is that liver resection or liver transplantation, most commonly for stage 2 HCC, remains the gold standard and provides the best chance for cure or long-term survival. Before we get into specifics, this is what a normal liver looks like, and large tumors can be cut out of the liver. Here you can see this was not HCC, but colorectal mets. We removed a large tumor from the right lobe and most of the left lobe, and we preserved about 25% of the liver here, and that's just enough for the patient to function and survive. And even basketball-sized tumors can be removed. Dr. Paul Manga mentioned in his talk about the rare fibrolamellar variant. We had a young 29-year-old male that's in the hospital upstairs and literally had a 20-centimeter tumor that weighed over 15 pounds. That was a fibrolamellar HCC that we just resected on Tuesday, and he should be able to go home hopefully tomorrow. Our liver cancer and transplant service started in Pittsburgh in year 1981 when Dr. Starzl came from the University of Colorado to Pittsburgh. Here's our Cathedral of Learning. And Dr. Starzl passed away about 3 years ago, sadly, just prior to his 90th birthday. But his influence was so important that Pittsburgh Magazine 3 times made him Man of the Year. And even for those who love our beloved hockey fans, when they won back-to-back Stanley Cups in 90, 91, and Mario Lemieux got Hodgkin's lymphoma and beat it. And the byline was Mario's courageous return, but yet Dr. Starzl still got the cover, and Mario got only the background story, which shows you the importance of Dr. Starzl and his influence in the Pittsburgh region and the entire globe for that matter. So I won't belabor the statistics. You've heard them, about 40,000 cases. One of the slides shows that 42,000 last year, rising in cirrhotic, 3 to 5% per year. Hep C, which is fading, alcoholism, and the explosion of fatty liver disease are the major risk factors. And we've already said the only chance to cure it is to cut it out or switch the livers with liver transplant. Some of you may be wondering, well, how many liver transplants have been done or are done in the United States? So the data is on a national database called OPTN, which has the government contract, and you could just Google OPTN and then pull up all this data. It's widely available. There's 189,000 cases of liver transplant have been done since we started recording it in year 1988. And for 10 years, statistics were humbling. From 2007 and prior to that to 13, it was only a little over 6,000 liver transplants per year. And we've made pretty nice headway in the last 7 years, where you can see a rise in the curve to now the last 2 years, 2019-20, nearly 9,000 liver transplants. So in part, that's better organ donor awareness and people giving either self-donating their livers on their driver's license or the family members graciously donating to save lives. How good are we at liver transplantation? If here, the most recent data from the government website, OPTN, 1, 3, and 5 year survivals for all liver transplant recipients in the USA, 91% 1 year, 83% 3, 75%. What about if we subset out those who actually had a liver transplant for hepatocellular carcinoma? It's nearly identical. 1 year the same, a little bit less at 3 year 80 and 5 year 70%. And these were liver transplants done between the years 2008 and 15, so pretty modern cohort to give us the 5 year follow-up. Nonetheless, we still have a critical shortage of organ donors in the USA. As of this website is updated every 2 weeks. So this was a week ago, October 21st. There are 11,722 patients on the wait list in the United States, but yet So 11,700 waiting, but last year we only had 8,900 liver transplants. So we're about 3,000 livers short. And you could say, well, what about if we do more living donors? Well, in year 2020, only 491 living donors were done in the United States. The vast majority were deceased donor. So the living donors only account for 6% of the total number of transplants. So most people need to wait for a cadaveric donor from someone who passes away from either a car accident or a stroke, and then the family donates. What are the consequences of being 3,000 livers short per year? Well, last year, 1,078 patients died over the year. So that's about 3 patients per year, 3 patients per day die waiting, and another 3 to 4 were removed because they were too sick. So we really do have a organ donor crisis, and patients are dying while they're waiting on the list. You might be wondering, well, what's the landscape in Pittsburgh? So these are the statistics right from the website. How many liver transplants were done last year in 2020 in Pittsburgh? Well, UPMC Presby, 149 liver transplants were done. And note, it's Dr. Humar, who's our chief of liver transplants, specializes in live donor. More live donors were done than deceased donors. About 60% of the total liver transplants were live donor, 91. Children's Hospital did 32 liver transplants last year. AGH did 42, and the VA did 37. So in the Pittsburgh region, with 4 programs, we've had 260 liver transplants per year. To put that in perspective, when I was an intern here back in 1988, and the second year was in 89, we did 550 and 600 at a combination of Presby Children's and the VA. AGH didn't have a program back then. And the reason the numbers have gone down is because back then there were not as many programs, but now nearly every university has a liver transplant program. There's approximately 120 liver transplant centers in the United States. So there's intense competition for the donors, but 260 is still a good number for the Pittsburgh region. How about the cancer outcomes with the open liver resection for HCC and comparing it to laparoscopic? Here's the data showing 5-year overall survival in comparative studies of lap liver resection, LLR, versus open liver resection for HCC. These are the 2 columns. 5-year survival. And one of the criticisms when we started doing minimally invasive liver resections, we'd be compromising outcomes, but the data hasn't shown that. From 2001 to 2016, there were 978 lap livers compared to 1,400 open liver resections, and not a single study showed any difference. So NS means not significantly different. 5-year survivals in the 50 to 60% range for either lap or open liver resection. And the data together shows that lap liver resection has comparable 5-year overall survival versus open liver resection for hepatocellular carcinoma. This is one of the biggest studies of propensity score match, which means the tightest matching of 31 centers in Japan. The patients were well matched for gender, child score, liver function, which is ICG clearance, presence of hepatitis, tumor size, number, location, extent of resection, 387 patients in each group, and the survival curves were nearly superimposable, equal survival in lap versus open liver resection. This is the only randomized clinical trial that's been done in the field for HCC. It was a small study comparing child's age, 25 lap to 25 open. The study was done in Egypt, so we applaud them for doing that. The lap liver resection had shorter OR time, shorter length of stay, less narcotic use, and a quicker time to diet versus open liver, but no difference in blood loss, transfusions, margin negative rate, overall complications, or 3-year midterm survival rate. So it shows there are benefits to lap liver resection. Positive randomized clinical trial in favor of lap because of the clinical benefits, but same cancer outcomes. Here's a series with Pittsburgh and others put together looking at nearly 10,000 cases of laparoscopic liver resection. 2/3 were done for cancer. And in those cases done for cancer, HCC, 50% of the cases are for HCC, 26% for metastatic colorectal cancer. Mortality was less than 0.5%. Lap liver resection had better clinical outcomes, less complications, less blood loss, less transfusions, shorter length of stay versus open liver resection in a meta-analysis of nearly 3,000 of these cases. Here's an example. Some of you may wonder, what does cirrhosis look like? I showed you earlier that smooth brown liver. This is what cirrhosis looks like. The liver is bumpy, it's rock hard. There's a massive portal hypertension, recanalized umbilical vein. These are collaterals or varices. Here's a small HCC tumor in a 78-year-old man. If we open this person for open liver surgery, he would probably decompensate because you would get massive ascites, you could get variceal bleeding. So the key is to stay laparoscopic. And going in, here's what the HCC looks like. It's white, yellowish in color. It's soft or fleshy. It's not rock hard like colon adenocarcinoma. It's easy to rupture, and we get 5 to 10 of these a year coming in with spontaneous rupture. And here's a picture with it completely resected laparoscopically, where we don't decompensate the liver because we don't interrupt any of these varices. And that's what the cancer looks like resected. And this is the picture laparoscopic, just like laparoscopic gallbladder surgery. Even in more advanced cirrhosis, the patients tolerate this. As I'll show here, here are about 8 papers published looking at, couldn't we now extend from child's A to child's B cirrhotics? We published a paper in 2018 looking at our series of 26 cases, and there were a smaller series. And then there's a large series that was just published this year in British Journal of Surgery from Roberto Trossi and the team, looking at international study in 17 centers. UPMC was one of them. There were 382 livers, 160 lap versus 222 open for HCC, all child's B cirrhotics, and then a subset of propensity score matching 100 to 100. The lap liver resection had less blood loss, transfusion, post-op ascites decompensation, less morbidity, less major complications, and shorter length of stay. No difference in R0 negative margin rate, both 95 versus 6, and long-term survival was comparable, maybe even a little bit better, but not statistically, trended towards 65% 5-year survival lap versus 47% open. How about our performance? We looked recently at our performance in 1,000 minimally invasive laparoscopic liver resections published last year in JAMA Surgery, and we divided into 3 periods: our first 200 cases from 2001 to 7, our next 400, and our subsequent 400. And what the data shows in this table, comparing periods 1 to period 2 to period 3, we got better. The parameters improved. OR time shortened, transfusions decreased. The percent of cases that were pure lap were almost 3/4. The complication rate decreased from period 1 of 15 to 5% in periods 2 and 3. More background cirrhosis we could tackle. The percentage of total lap versus total cases compared to open increased to about 1/3 of our cases are no laparoscopic, and our conversions remain low in all 3 time points. So it shows that laparoscopic liver resection indeed has patient benefits, and you could take on more challenging cases without having decompensation. Our next talk will be, the next speaker is going to talk about regional liver therapy. So I'll just have 2 or 3 slides to introduce the topic. Here's an Asian woman with hepatitis and a massive hepatocellular carcinoma, AFP over 12,000 here, got some regional liver therapy, transarterial chemoembolization, initials are TACE. For 12 cycles, the tumor melted away, the alpha-fetoprotein normalized, and she lived for many years after these regional therapies. Sometimes we can even use the regional liver therapies as a bridge to resection or transplant. Here's a large left lobe hepatocellular carcinoma. Back in 2003, the FP was 31,000 and got regional therapy ×4, and the tumor shrunk down now to just over 50% shrinkage to this tumor. Then we were able to go in and resect the patient. The AFP hadn't normalized. It was still nearly 800, and after resection, we normalized the patient and give the patient a chance for cure. 1 year out, the patient was disease-free. We'll hear more in the next talk, I'm sure, about internal radiation called Y. Y stands for yttrium. Yttrium-90 is Therasphere. It's a beta emitter with a short half-life, and it penetrates about an inch or so, a few centimeters in the liver. And this is good for, in addition to regional therapy, for regional liver therapy. Here's an example of a patient on angiogram. You see 3 tumor blushes, which means cancer. 1, 2, 3. After radiation beads injection, the HCC is gone or wiped out. So another option for regional liver therapy. Let me summarize by saying when we identify HCC, what do we do in the clinic? And so this is what the thoughts go through our mind. The first question you should ask is the patient now, or will they ever be a resection candidate? And so if you can resect them in non-cirrhotic or early child's a single lesion, then they should get the resection. That gives them the best chance for cure. But if they're not a resection candidate, then the next question to ask is, are they a liver transplant candidate? And the rules in the USA are that a stage 2 tumor, stage 2 HCC means 1 tumor up to 5 centimeters, 3 lesions up to 3 centimeters. So you can have a 1 centimeter, a 2, and a 2. That would be a stage 2, and they can get on the transplant list. And after 6 months on the list, they can get bonus points. The stage 1s, which means a single tumor under 2 centimeters. So if it's a 1 centimeter tumor, it's an early stage 1 liver cancer. They don't get bonus points. And you can have a vascular invasion or spread outside the liver. Then they could be a transplant. If they have a living donor, then they get worked up, which takes about a month. And then a suitable donor, they can go on the list. If they don't have a live donor, you have to ask, how long is the wait list going to be? Because in some states, the wait list or regions of the United States, it might be anywhere from only 3-month wait list versus some states with intense competition, the wait list could be 2 years. And in Pittsburgh, if you're a blood type O, which is the most common, and you get on the list, it could be a 1 to 2 year wait. So we tend to bridge them with neoadjuvant therapies, laparoscopic, radiofrequency, microwave ablation, chemoembolization, or yttrium, sometimes even medical therapies, and hopefully to get the liver transplant. We're going to hear a little bit later, when they're not a transplant resection or regional liver therapy candidate, then there's many systemic and immunotherapies. We'll hear all about this from Dr. Dula Manga, so I look forward to that update. But 10 years ago, all we had was sorafenib. Maybe 12 years ago, the SHARP trial approved that. So we've come a long way for regional therapies, and now we're combining these with systemic and immune therapies, combined with regional liver therapies. We're even talking about using some of these as a bridge to transplant. So the data keeps evolving. It's an exciting time to be involved in multidisciplinary teams managing hepatocellular carcinoma. I will conclude by saying that surgical resection or liver transplants the only chance to cure HCC. For those who are not cured, we can often extend years of life. Laparoscopic liver resection for HCC has been performed in thousands of patients worldwide with comparable oncologic outcomes and clinical benefits with less decompensation, and they can be done in selected Child's B cirrhotics. Multiple regional and systemic chemo and immunotherapy options exist. So that concludes the talk, and thank you very much.